Welcome to a new season of To Your Health. It's October, and you'll be seeing a lot of pink. Breast Cancer Awareness Month is October, and pink is the color that recognizes that. Today we have two experts to discuss breast cancer awareness, prevention, treatment options. We also have a new co-host, Dr. Laura Boyd. Dr. Uribe, her practice has grown as her responsibilities have also grown. So Dr. Boyd is our new co-host, and welcome, Dr. Boyd. I'm excited to have you with us. You've actually done a show with us once before in the past. I believe we were talking about heart health.
Correct.
So that was another month when everybody was wearing red, and I believe it was February. So welcome aboard. And she's also brought a guest today, Dr. Christine Gresick, and we will be talking to both of you ladies in just a few minutes. But right now, I want to know a little bit about Dr. Boyd. Tell us a little bit about yourself.
Well, thank you for having me here. I am from the Chicago area, born and raised. I am a family physician with the Elmhurst Clinic here in Addison. Been with the clinic for 9 years, so I have a good growing practice. I did do all of my education in Chicago. I went to Loyola for undergrad. Most people are surprised I actually majored in Spanish language, so I speak Spanish. I studied abroad, so people are always a little surprised by that. And then I went to Rush Medical School, and I did my residency at Illinois Masonic.
And now you have offices here at the Addison Health Center at 303 West Lake Street, and
Correct.
you are on the second floor.
Correct.
You're a family physician?
Correct.
So we come to you for everything.
Yes, I see kids, adults, all the way up. So often I will see grandparents and their grandkids, which is really cool.
See, that's kind of nice, right? Because, grandma knows you, mom and dad know you, and now you're seeing the grandchildren. So you really get to know the history that way.
Correct.
Of family history, which has a lot to do with breast cancer and breast cancer awareness, because history is sometimes it's a risk factor.
Correct.
It's a risk
Yes.
factor. Dr. Gresick. Dr. Gresick is a breast cancer oncologist. No, I'm sorry. Oncologist that specializes in breast surgery.
Correct. Surgical oncologist.
Because it's not always breast cancer.
Correct. About 50% of my practice is patients that have breast cancer, but 50% of them are patients that we're trying to ward off breast cancer with risk prevention and sort of high-risk screening mechanisms so that we can hopefully prevent them from getting cancer to begin with.
And when you say high risk, we just kind of mentioned that family history, but what are some of the other risk factors?
So I always tell patients that there are modifiable versus non-modifiable risk factors. So we can't change who our parents are, and so family history is something that is not modifiable, and it's something that can put a patient at risk for developing breast cancer. And then there are those things such as hormonal influences that a woman will go through during her lifetime that may change or influence her percentage risk or chance of getting breast cancer during her lifetime. And those would be the age at which she begins her first periods, how old she is when she has her first child, whether or not she's been exposed to things like oral contraceptive therapy or hormone replacement therapy. And those are things that we ask patients when they come in so that we can get an idea of what their risk is compared to the average risk woman.
And it also gives you an idea of their background.
Correct.
But now, Dr. Boyd, before we get into the real specifics about breast cancer, I know you wanted to talk about some of the other conditions and issues related to breast pain and the discomfort that women sometimes see and feel.
Correct. As primary care, often I have patients coming to me, they're scared, they come in the door, they say, I have breast pain, do I have breast cancer? That's their biggest fear, is that immediately if they have pain, they're thinking worst case scenario of cancer, but really that's an extremely small percentage. that will have any breast cancer associated with pain. Most of the time it can be hormonal, so around premenstrual time. For many patients, just like they have cramping, headaches, low back pain, they'll get some breast tenderness about a week before their period will come or menses will come, and that's pretty common. But for some people, it can be more extreme and very worrisome for them. Other causes, sometimes it can be that they have a cyst, or for postpartum mothers that are breastfeeding, it can be that they might have an infection called mastitis, which will cause some redness and pain and even fevers at times. There's other conditions, fibrocystic changes that people can have, and that's kind of lifelong. They'll kind of describe that they always have lumpy breasts, and those patients might have some pain associated with that.
And sometimes that's fairly common.
Correct. Yes, and it's important. I always encourage my patients to come in and talk to me, so to get an exam, to know for sure what's going on, to direct them in the right path. Because most of the time, these patients don't need to have imaging, especially if they're young women and they're associated premenstrual. Then this is kind of a normal cause and effect that will occur every month for them. There's some things that they can change. We'll recommend patients to decrease their caffeine intake, or to make sure they're eating a good, healthy diet, because sometimes high-fat diets can increase the breast pain. Sometimes we'll recommend doing some vitamin E supplements, like 400 international units daily can help. Smokers, I encourage patients always, of course, to stop smoking. That sometimes can be associated with the breast pain also.
But it's not always something to get panicked about, because I think that's what people do. Oh, I've got a pain, oh my God, it must be something awful.
Yes.
It's not always something awful. Sometimes as you age, things change, and what didn't hurt yesterday hurts today. Believe me, in more ways than one. As you get older, things change. But let's talk a little bit about breast cancer detection and the steps that we should take, that women can take on their own or with their doctor in the detection of this. So,
and that's part of the reason too. I asked Dr. Gresick to come join us today, because it's quite confusing right now. There's a lot of different recommendations, and so patients will come in. They'll be in their 40s, and they'll say, "But wait, I heard that you're not supposed to start till your 50s now." And so we have this conversation, kind of going into, well, what's your background? What's your family history? Are you a smoker? And those type of things kind of guides us in the right path. But it is confusing, because right now there's a couple different organizations that have different recommendations regarding screening mammography at this time, and I would like Christine to kind of just comment on that, because it is confusing.
And there's so much that's on television.
Correct.
Yes.
That's telling you, oh, you should do this, and oh, you should do that, and really, what we forget is those are commercials. They're there to sell a product. You really need to work with your doctor, I believe.
And I think there's a big distinction between screening and what we consider diagnostic imaging. So if a patient has pain, such as we just were discussing, a pain, a lump, a change, discharge from her nipple, a rash, anything at all, they are not appropriate candidates for screening. In fact, they need to see Dr. Boyd or their primary care physician and be referred for special imaging, so that we are honing in on that specific symptom and problem to look for that specific area. But screening is very confusing, because over the past several years, different societies, as Dr. Boyd mentioned, have recommended perhaps we can go every other year. Do we really need to go every year? And I think what's confusing is that breast cancer screening is not a one-size-fits-all. In fact, many women need to have customized screening plans based on their family history. Our recommendations with regard to family history is that if you have a first or second degree relative, which would be one branch or two branches off the family tree when we talk about the family tree, we would recommend that screening would start 10 years before the earliest age of diagnosis. So for instance, if your mother had breast cancer at the age of 45 years old, her daughter needs to start screening at 35 years old. And so talking to physicians about family history becomes so important even earlier in life, before our 40s, to capture those women that may be at particularly higher risk.
And they need to know that. This is the first time I knew that. I knew it was something that it could be, if it's in your family history, you are a higher risk, but I didn't know that 10
Screening, so screening does change. And in fact, the type of screening that we do, most generically our gold standard is of course mammography. It's been around forever. I don't see it going anywhere too soon because it is an inexpensive test with low radiation exposure that is easy for us to acquire images very quickly and help guide both treatment decisions as well as a goal for surveillance in the future. And multiple societies are sort of having an argument between whether or not we need to screen once a year or every other year. And that's particularly for women who have no family history of breast cancer. And in those patients, what we say is that when we look at the data and we see that women who get screening every year versus every other year, we do know that women who get screening every year, we do find more cancers and we find them at an earlier detectable rate, which means less invasive treatments, better outcomes. And so it is my bias in our practice and at our cancer centers at both Elmhurst and Edward hospitals that we follow the National Comprehensive Cancer Network guidelines, which do advocate for annual screening after the age of 40. And again, with the rule that we should start screening 10 years earlier than the earliest onset of diagnosis if there's a first or second degree relative that has had breast cancer in your family.
But how many years after? You said you started 35, if you have history, 40, if not, but how old do you go? I mean, do you go until they're 80 and 90?
We say to your health. We say till there would be some other type of medical condition that would preclude either the ability for us to acquire those images, or I think a lot of our primary care physicians will judge that, Dr. Boyd can probably speak to this, based on whether they have other comorbidities such as diabetes or cardiovascular disease or things that may be limiting their lifespan. Ultimately, screening is designed because it saves lives. So if a woman comes in for annual mammograms and we can capture something at an earlier stage, she's going to have a much better survival and outcome. And
that's what people need to know, because the sooner you can detect something, the more treatable it is.
So 95% of patients who are diagnosed with an early onset breast cancer will die of another cause, and it will not be their cancer. And it's the first thing I talk to my patients about when they're diagnosed, is that this is a very survivable disease if we capture it early. And so my patients often become their advocates for their friends and family and neighbors, because if we go in for regular screening, we have very good outcomes.
And it is a screening. It doesn't. Well, I shouldn't say it doesn't hurt. When mammography is not painless, but it's better than alternatives. Now, there's this 3D mammography. What is 3D mammography?
So the fancy word for 3D mammography is tomosynthesis, and essentially what it's able to do is reconstruct the breast versus two images that we used to be able to obtain with our conventional 2D screening mammography. Tomosynthesis takes advantage of the fact that we can sort of peek around the breast and look at it from different angles. And instead of looking at it in just that 2D dimension, we're actually able to acquire 1 millimeter thick slices through the breast, and we're able to improve the sensitivity of our screening for women. I do foresee this replacing 2D mammograms within my practice down the road. 3D mammography is particularly important for women who have what we call dense breast tissue. So 50% of women in our screening population will have what we call dense breast tissue, which means they have greater than 50% glandularity seen on their mammogram. And very few women understand or know what their breast density is. So that's something that all women should be aware of. It is readily available on their mammography report that they can get. We give our patients through Elmhurst Edward access to all of their records through something called MyChart, and so patients can very easily go on there, look to see what their density it is. And if they are not receiving 3D mammography, we know that the sensitivity of screening with that tool, if you have dense breast tissue, is much more accurate than if we do a 2D conventional screening. So it is something that I encourage patients to talk to their doctors about, to talk to their primary care physicians about, because as I mentioned, 50% of patients are candidates for it, and a lot of women don't even know that it's around.
And it's not done any differently. The patient doesn't really know that. And then mammography also has gotten a little bit easier.
It is. Our pads are a little bit better, a little bit more comfortable. The 3D acquisition of images.
A little bit more comfortable, not a lot more comfortable.
The 3D acquisition of images, you're entirely correct. Most patients won't even realize they're having it done. Our machine actually rotates around the breast tissue. It doesn't cause any additional compression or pain or discomfort. We've timed it. It takes 4 seconds longer than the conditional or the traditional 2D mammogram. But it's the difference between being able to potentially detect up to 60% of things that are going on versus greater than 80%. So it's a highly large improvement in terms of our sensitivity of screening, particularly for these women that have dense breast tissue.
It takes a peek around another side.
It does. It's a different way of looking at things, and it allows the radiologist to really hone in on tissue and understand, is this just dense overlapping breast tissue, or is there a problem happening within there?
Are they using this all the time now, or is it something that is more specific that a doctor has to put on the request for the mammography?
Presently, it is something that has to be ordered by the doctor. Most of our systems are very open to, if a patient comes in and gives a request that they've heard of tomosynthesis or 3D mammography, we are very capable of reaching out to the ordering physician's office and accommodating that need for our patients, because we feel so passionately about it at our breast center that that's so important for patients.
So once again, talk to your doctor. Now, take us through the process. If a woman has a suspicious mass, it's detected, what happens next?
Well, often what will happen from my end as a primary is I'll get the call from radiology that they have a concern about a lesion, and then we set up the patient to have an ultrasound guided biopsy done. That way to get the tissue to get a further diagnosis. And usually the patient will actually know kind of right away when they go in for the mammogram, because we'd be sending them for a diagnostic mammogram that Dr. Gresick had referred to, that spends a little bit more time, gets a little bit more imaging, often is done with an ultrasound. So at that time, at least with Elmhurst, Edward Elmhurst system, the radiologist will speak to the patient right away and let them know that there's a concerning lesion and that we're going to set you to come back for an ultrasound-guided biopsy to get for more information. And it's nice at Elmhurst, they actually have a system where they have a breast cancer nurse navigation kind of system set up that they can come back and get the results kind of within a day or two and sit down and know the path which way this is going. And we try to get patients in fairly quickly to either see Dr. Gresick or other breast surgeons and the oncologist to get things moving if that's needed.
And really, the quicker you know what's needed, the better, because that waiting, that anxiety causes other issues,
Absolutely.
I think,
And I think what's reassuring that patients need to know is that when we recommend a breast biopsy, whether it's because we feel something, we see a mass, or we see changes on mammogram that prompt a biopsy, 80% of the time the biopsy is benign and it is not cancer.
But you gotta know that.
I tell patients all the time, I say, 1 in 3 women will end up with a breast biopsy during her lifetime, and only 1 in 8 women will get breast cancer. So a lot of us are going to have to go through this, and we can't always panic that there is going to be breast cancer. There are a lot of other conditions that can cause us to be suspicious about imaging or our exam that, of course, are going to cause us a lot of anxiety, but they don't always mean a bad news at the end of the day.
And also, if it is breast cancer that's diagnosed, or something that has to be treated more thoroughly, there are many options.
Absolutely.
Correct.
And that's where you come in, because there are many options.
So I oftentimes will meet patients, sometimes they see patients before they've had their biopsy, if there's something suspicious that the primary care physician's not sure which way to direct the patient. But I oftentimes will see patients after they've had a biopsy. Some biopsies, though they may not be cancer, may still require a surgical intervention, meaning we may need to take them out. Some biopsies may mean that we need to watch patients more frequently, and instead of waiting till next year, they may need to get imaging in 6 months or in a shorter time interval. If a patient has been diagnosed with breast cancer, it is true that less is more nowadays, and that we have many different treatment options with minimally invasive surgeries. Most patients are terrified about the notion of chemotherapy, and in fact, most early stage breast cancers do not require chemotherapy anymore for breast cancer.
See, those are new things.
These are things that, and in terms of other sort of treatments to prevent things from coming back, such as radiation therapy, what used to cause a lot of morbidity, pain, and discomfort for patients is now a much easier, shorter course. And most of my patients continue to work, take care of their kids, still have to make dinner, take out the garbage during treatment.
Have to do
they
the
still
routine.
do the routine, and they do it all throughout their treatment. And again, 95% of those early detected will sort of live a nice, long, healthy life, and something else will be what ends up becoming a problem for them down the road, not their breast cancer.
Well, what can we do to decrease the risk of breast cancer? I mean, really, there's things you can do to help yourself to decrease your risk, which I think we kind of touched on in our conversation already. But can we kind of go through them again? What do you preach to your patients?
Healthy living. There are, obviously, like Dr. Gresick was saying, referring to family. You can't change those things. There's the modifiable type stuff, like obesity has an increased risk of breast cancer, increased alcohol intake, smoking, those types of things. High dose, like hormone replacement therapy, there's a lot of controversy still with that, but it's more the higher dosed estrogen, progesterone replacements that patients need to be watched a little bit closer with that. And those are things that you can change. Obviously you can't change your family history, and so you have that, but the things that you do have power over, I really encourage patients to pay attention to that, start exercising regularly, all those things. But of course, people do all that stuff, and unfortunately they still get breast cancer. So I don't want to say that.
No, but you can't help yourself.
Correct.
I mean, you can help.
Absolutely.
The smoking is a big issue. That's something that's easily, well, it's not easily sometimes,
for some.
but it can be done. And the same with limited alcohol. Now, there was something else you touched on earlier, was vitamin E.
Yes. Like 400 international units. There's some, I also was looking into that a little bit. If you go to really high doses, then there's some controversy that you're increasing risk for different types of cancer. So just kind of, following a nice healthy diet, eating your, vegetables, fruits, lean meats, that types of things.
They have the natural vitamins in them.
Correct, exactly, yes. And the thing from a primary care physician standpoint, the most frustrating thing is when patients say, well, I'm not going to do this because I don't have a family history. Often patients will put off getting mammograms, screening mammograms, and that sort of thing because they don't have a family history. And I'm like, yeah, but there's always the first person. You're the first one, and so many of my patients have been the first ones in their family.
85% of women diagnosed with breast cancer have no family history.
But then family history, there were grandparents. First of all, your life expectancy is longer now.
Correct.
Sometimes you didn't know because the life expectancy was shorter.
Yes.
So we're living
Completely.
longer. We're going to find out more things. We're more
And our
aware.
technology is better. So things that we wouldn't have captured on mammography many years ago, we will now. And that's why we're actually seeing a higher incidence of early onset breast cancer, so that we're finding things when they're more curable in earlier stages. So screening becomes even more important because the earlier we find something, the less of a consequence it's going to be for the patient.
Screenings, but see your doctor, see your family physician first, and then go from there and let them tell you what you need to be. I really, people try to be their own doctors. Not a good idea.
Dr. Google.
Yeah, Dr. Google could kill you.
Yeah.
Dr. Google could kill you. Go to your family physician and do the screenings that you're told to do by your family physician. Now, we've got just a couple of minutes left. I would like to know how we can contact Dr. Gresick. So give us your information.
So I have I work for the Edward Elmhurst Health System, and I have practices located at the Nancy Knowles Cancer Center on the campus at Elmhurst Hospital, and I also have a office at the Cancer Center at Edward Hospital, and I split my time half and half between the two campuses.
And is there a phone number or contact where people can reach you? You don't?
630-646-6020.
Thank you. And Dr. Boyd, you're new with us, so we need to know, how do people reach you?
I'm at the Addison Clinic, that's considered the Edward Elmhurst Center for Health in Addison, and the phone number there is 331-221-9001.
Well, we thank you both for joining us. I'm looking forward to working with you this new season. And Dr. Gracek, you were phenomenal.
Oh.
You're just easy to talk to. And Dr. Boyd, the onus is on you to bring us somebody just as good next month.
Sounds good.
And we hope to see you back here again sometime. So thank you all for joining us. I'm Lucille Zucchero with Dr. Boyd and Dr. Gracek. And here's to your health.